Hello everyone, this is Dr. Sultan Manuddin Shaukat Ali. I welcome you to Ikramat Academy. I've completed my MBBS, MD and DNB in radio diagnosis. You know me as you have attended my lectures on pelvis, ultrasound of the obstetrics patient. Similarly, we have a series on ultrasound of abdomen, etc. So in this beautiful session, I'll be discussing about the ultrasound features of thyroid lesion, especially malignancies. So this is my second subsequent successive session on ultrasound features of malignancies. So before this, we have discussed about the tirades. So we have got sessions on tirades, 3 sessions. So I recommend you that before you start this session, आप लोग पहले tirades के session खत्म कीजिए, उसके बाद इस पे शुरुआत कीजिए. So you start this after you complete tirades. Okay. The next important thing is that I have also discussed in part 1 about the fundamental changes about the imaging features. Okay, and in brief about the pathogenesis. In this lecture of mine, I would be talking elaborately on 2 important malignancies out of 5 which I had told you. So let us start without any delay. Okay. Now, फिर से I tell you that when we come to malignancy features, okay, यहाँ पे in this I will be telling you that this looks like a follicular CA or this looks like a papillary CA. That doesn't mean that you give final impression as this is papillary CA of thyroid or this is follicular CA of thyroid. But here the main purpose is to understand okay, how a follicular CA looks on ultrasound, how a papillary CA looks on ultrasound. Also, we will be saying on how the metastasis in case of follicular CA is different from metastasis in papillary CA. दोनों में the major differences would be talked about in this session. Okay, so without any delay, let us begin. So when it comes to thyroid CA, uh, as I had already mentioned, but just to brush it up, the main CAs are number 1 follicular CA, okay, most important. Number 2 you have papillary CA. Number 3 we have anaplastic CA. Number 4 we have medullary CA. Number 5, although rare but not uncommon, we have lymphoma of thyroid gland. Remember, lymphoma not of lymph node, of the thyroid gland. Okay. Now, so in this session of mine, I will cover follicular CA and papillary CA, the imaging ultrasound features of both of this. Okay. Yes. So I've already told you in my previous session 1 that it is adenoma which might get converted into carcinoma. So I'll be discussing about the features of adenoma. Adenoma is benign, okay, and carcinoma is of course malignant. Okay, so I'll be discussing the features of both of this. When it comes to follicular CA, they are typically solid, very important. They can be both hypoechoic as well as hyperechoic. Now, point to be noted, a very important point is that follicular CAs can be hyperechoic, and that is the reason why you can confuse follicular CA with a benign lesion. Okay, now they can be they are usually homogeneous but can be heterogeneous also. Now, as they are homogeneous, they are often mistaken as benign lesions, and they are well marginated. And very important, the hypoechoic halo which you see, suppose this is a lesion, so there is a if the lesion is hyperechoic, you see a surrounding halo which is a hypoechoic halo. Now usually in benign lesions this hypoechoic halo is thick, but in this case the hypoechoic lesion is thin. Okay, it is thin. This is very characteristic. I'll be showing you the images of how the thin hypoechoic halo looks, and most importantly this shows hematogenous spread. This is a very important point, that it shows hematogenous spread. So normally if you see, if it's a hematogenous spread, it spreads through the lungs. Okay, and this can also spread to bones. And the metastasis which you see in bones are classically pulsatile mets. Pulsatile mets. So as they are highly vascular, the mets which you see in this kind of lesion are pulsatile mets. Okay, and also a very important point is that follicular CA can give rise to a special mets which is called as miliary metastasis. What is miliary mets? So if you see the lungs of this patient on X-ray, you will find multiple randomly distributed tiny millet-like nodules throughout both the lungs. So when you have this kind of pattern, a very important differential other than miliary TB is miliary metastasis, and the lesion or the malignancy which can give rise to miliary metastasis is again thyroid cancer, follicular CA. Now again, more common in females as compared to males. This I had discussed when I talked about Hashimoto's disease also. Okay. Now let us come to the imaging features. So पहले मैं बताऊंगा how adenoma looks, follicular adenoma, and then I'll come to malignancy, that is follicular CA. अब एक और important चीज जो मैं बताना चाहता हूँ वो ये है कि I'll be showing you a series of images. Okay, so in those images I'll be telling you uh, what what should be our thought process. हमारा thought process क्या होता है जब हमें अल्ट्रासाउंड पे इस तरह के लीजन दिखते हैं. Okay, that is what we will be talking about. चलो, get ready. So now these are 6 images in different patients. Now, if you look overall, other than image E, most of them are solid lesions. Image E is solid cystic, so I'll talk about that also. And most of these lesions, okay, all these lesions turned out to be follicular adenoma on ultrasonography. Sorry, on FNAC and biopsies. Okay. Now, let us come to image A, first image. So here you see that this is the left lobe of thyroid, and the lesion which is there within the left lobe of thyroid is this lesion. Okay, so it's a solid lesion, the solid lesion. And why I have not encircled it, because I want you all to look a very characteristic important feature, that is this one. Are you able to see this? This is a thin hypoechoic halo. Look here. So there is a characteristic thin hypoechoic halo. So solid with thin hypoechoic halo. Now, एक और बात मैं फिर से बता रहा हूँ, it is very difficult to tell whether this is benign or malignant on ultrasound directly, because this on thyroids would be at least thyroids 4. So you have to go for FNAC or biopsy in these patients, and this turned out to be a follicular adenoma. But whenever you have such lesions, never take risk, always go for FNAC. Okay. Now again, this is another. Let us come to image B. So here you are able to see a very well defined hyperechoic lesion, and what I want you all to see is this hypoechoic halo which is surrounding it. You can see this hypoechoic halo, okay, and this is isoechoic, iso to hyperechoic to the gland. Okay, again this turned out to be follicular adenoma. Now this is again a lesion which is solid lesion with few heterogeneous areas, heterogeneously hypoechoic areas within it. So sometimes the follicular adenomas can be heterogeneous also. So here again you see this is a solid lesion predominantly with a thin hypoechoic halo, and what you are able to see is a small cystic change. So sometimes cystic changes can occur, but if you see the lesion is predominantly solid. So lesion is predominantly solid. Okay. Now let us come to the another important lesion here. So this is again a lesion. Again, this lesion is showing solid as well as cystic areas. So you can see that within the lesion, this area, the lobulated area, this is a solid area, but these are all cystic areas within the lesion. So now in this case, again, as this is predominantly solid, this is a suspicious nodule, at least we'll go for Thyroid 3. And here, can you see that this is the solid component? So we have to plan FNAC for this lesion. And when you plan FNAC, what should be your direction of taking FNAC? So you have to take FNAC in this direction. That is, you have to take it from the solid component. So FNAC should be planned from the solid components. Very important. Okay. Although this turned out to be a follicular adenoma, that's a good news for the patient. But never take risk from radiologist side or from sonologist side, because you have to be very careful in such types of lesion with solid components. Okay. Now let us see this lesion. Again, this is a hypoechoic lesion. So whenever it's a hypoechoic lesion, you have to be suspicious. There is increased vascularity in this lesion. So always plan an FNAC. Although this turned out to be adenoma, but always have a suspicious mindset in these forms of lesion, which are solid, increased vascularity, or heterogeneous, or a cystic lesion with multiple solid components within it. Always go for FNAC or biopsy in this form of lesions. Okay, so this was about follicular adenoma. Although follicular adenoma is not an ultrasound diagnosis, this is the diagnosis of FNA. But I have shown you a retrospective uh, अप्रोच. सो वेयर आई हैव शोन यू कि ये जो लीजन्स थे हमने सस्पेक्ट किया था एंड ऑन एफएनएससी दे टर्न्ड आउट टू बी फॉलिकुलर एडिनोमा. ओके, आपने इसे ऑन पेपर फॉलिकुलर एडिनोमा लिखकर नहीं देना है. यू शुड ऑलवेज गिव इन द फॉर्म ऑफ टायराइड्स, वेदर टायराइड्स 1 2 3 और 4 5, not in terms of follicular adenoma or follicular CA. Okay, that is very important. And always जब भी इस तरह के स्कैन्स आए, इस तरह के लीजन्स थायराइड में दिखे, द नेक्स्ट इंपॉर्टेंट थिंग यू शुड डू इज एटलीस्ट एक्सरे ऑफ द चेस्ट, एंड यू शुड लुक फॉर lymph nodes in the neck. Most important, you should look for lymph nodes in the neck. Okay, because they might show metastasis to the lymph nodes, although commonly shows a hematogenous mets in case of follicular CA. Okay, so you should screen for chest, you should screen for neck nodes. Okay, come on, let us move to follicular CA. Now these are two important images. Okay, so here you are able to see that there is a very well defined lesion, and this lesion in the thyroid gland is showing extracapsular extension, okay, in posteriorly, and this lesion is solid, smoothly marginated, slightly hypoechoic as compared to that of the thyroid gland. Now here you can see that this lesion is showing partial halo in this region, and there are some cystic areas. So all these are anechoic cystic areas within the lesion. Okay, now so this lesion on FNA, it turned out to be follicular CA. So very important, whenever, so this is a thyroid 4 lesion and it turned out to be a malignancy. Okay, very important. So whenever you have such a lesion which is solid, okay, even if it is a hyperechoic, but if you see that the halo is interrupted, halo is small, the peripheral halo is small in size, then always get an FNA done to rule out neoplasms. Okay. Now with this in our brain about malignancies, that is papillary follicular CA, let us come to the next important group of malignancy, which is papillary CA. Okay, now papillary carcinomas, they are the classic Thyroids 5, which we discuss usually. So we have already discussed about Thyroids 5. So all these Thyroids 5 features we have seen, they classically mark the papillary CS. Okay, now before I come to what are the various important features, I would like to inform you that papillary CA, one of the most important risk factor for papillary CA is exposure to radiation. Okay, exposure to radiation. This is one of the very important risk factor for papillary carcinoma of thyroid. Okay, now Just to complete the topic, I will also tell that follicular CA, which we have seen just before this, one of the very important risks for follicular CA is MNG, the presence of multinodular goiter. So for follicular CA, one of the important risks is multinodular goiter. So MNG can get malignant transformed into follicular CA. Similarly, follicular adenoma can get transformed into follicular CA. Okay. Now, when it comes to papillary CA, radiation is a very, very important risk factor. Now, the features which we had discussed for uh, papillary CA, that is hypoechoic nodule, solid nodule with microcalcifications and sometimes peripheral calcifications, taller than wider, lobulated margin, extra thyroid spread, lymphatic spread. These are all features of papillary cancer. So I would give you a small illustration. If you remember that, it becomes very easy to remember all important features of papillary CA, that is this. So remember that this is a oval, sometimes might have lobulations, taller than wider lesion, okay, and very important, this can have multiple microcalcification. Microcalcification. So taller than wider lesion, it can have multiple microcalcification, very important. And very, very important is it spreads via lymph nodes. So lymph nodal spread. And there is a very special feature. Now lymph nodes can be seen in multiple disease. बहुत सारे differentials होते हैं जगह lymph node दिखते हैं, reactive हो सकते हैं, ट्यूबरकुलोसिस हो सकता है, मेटास्टेसिस हो सकता है, पेपिलरी सीए का मेट्स हो सकता है, बट हाउ टू डिफरेंशिएट, आप इन सबको डिफरेंशिएट कैसे करोगे, व्हाट इज द वे टू डिफरेंशिएट देम. So in order to differentiate this, a very important thing which you see in patients with papillary CA, the mets in papillary CA shows multiple calcific area, multifocal calcification. So whenever you have multifocal calcification, that is a very, very important sign in lymph node that this can be met from papillary CA. So you should not get confused कि ये tuberculous node होगा. जब भी lymph node enlarge हो, always look for thyroid gland. आपको thyroid को screen करना है. Whenever you see lymph nodal enlargement, always screen thyroid gland to look for any underlying thyroid lesions. That is must. Okay. Now, abhi I'll be showing you many of the important images. That is how papillary carcinoma presents with. If you remember those, it becomes very easy for you to understand that how can this be papillary CA. So here are 9 important images. All of this on FNSC turned out to be papillary CA. Okay, so let us start from image number 1 and I want you all, मैं चाहता हूँ कि आप images देखो और you try to identify कि suppose patient आपके पास आया एंड उसके अंदर इस तरह का इमेज दिखा, तो थॉट प्रोसेस क्या होना चाहिए, क्या फीचर्स हमें आइडेंटिफाई करने हैं टू टेल दैट दिस इज malignancy or this is papillary CA. Okay, now let us start from image A. So here you are able to see a very well defined hypoechoic solid nodule. So most important features are this is hypoechoic and solid. So whenever you have hypoechoic solid nodule, always get an FNA done to rule out papillary CA. Okay, now let us come to image B. Here in image B, you are able to see a very well defined, again this is hypoechoic lesion. So what I want you all is to notice this, the foci of calcification. So what are all this? These are microcalcifications. Whenever you have microcalcifications, this favors that this is again papillary CA. Okay, now let us see this. This is a image C. Image C is a large lesion. It's solid. And if you see, there are few hyperechoic areas also, hypoechoic areas also, so it is heterogeneous. And if you are seeing very well, you can see all this foci of microcalcifications. So there are lots of microcalcifications, solid lesion, heterogeneously hypoechoic lesion. Okay. Similarly, let us see image D. Here, if you see image D well, you are seeing a lesion which is having, yes, so any guesses what is it having? This is having lobulations. Lobulations. And can you see that inside it there are lots of microcalcifications also. So lobulations, microcalcifications again favor malignancy. Okay. Now look at this image now, image E. Here you are able to see a lesion which is hypoechoic as compared to the gland, but very important. Are you able to see this margin? This is ill-defined. What do you mean by ill-defined? That is, you cannot say where is the lesion stopping. Lesion कहाँ खत्म हो रहा है, normal thyroid कहाँ शुरू हो रहा है, you're not able to say. So whenever you have ill-defined lesion, hypoechoic, always go for FNA of these lesions. Okay. Now again in this image F is again an interesting image. Here you are able to see that this is the thyroid gland, the trachea. This is the left lobe of thyroid gland, isthmus, and within the thyroid gland you are able to see this lesion. And very important, what do I want to show you? Extra capsular spread. So it is going beyond the capsule, extra thyroid involvement. Okay. And it is having lobulations with extra thyroid involvement. So extra capsular spread, and the lesion is solid, hypoechoic. Okay. And most important feature which I want you all to see in this image is, you see that, you see the height of this is more as compared to the width. So this is taller than wider. This is taller as than wider. So this is again a feature of malignant lesion. This turned out to be papillary CA. So if you see all papillary CAs, जितने भी हमने देखे हैं, ये सब hypoechoic होते हैं. Microcalcification, lobulations, taller than wider lesion. These are all important features. Now usually it shows punctate microcalcification, but in this case you see a hypoechoic lesion which is showing peripheral calcification. So sometimes peripheral calcification can also be there in case of papillary CA. Now again here in image H you are seeing a very classic lesion with lobulated margin, multiple shadowing from the calcifications. Okay, you are not able to see the posterior margin. Again, this is a feature of malignancy. Now here you see that there are few peripheral calcification with side edge artifacts, and you can see this is a hypoechoic lesion. Again, small hypoechoic lesion, but it turned out to be malignancy. That is papillary CA. So if you want to summarize all important features of malignancy, that is papillary CA, they are hypoechogenicity, lobulations, and ill-defined nature, and wider than taller. Okay. Now we will come to the lymph nodes which are seen in case of papillary CA. So before lymph nodes, I will be speaking on what are the changes. Sometimes, although all of these are solid, we have seen that in follicular CA also sometimes you might find cystic changes. I showed you this image, right? Now you will see that in case of papillary CA also, sometimes you might see cystic changes. So like in this case, you are able to see that there is a lesion in the thyroid lobe with cystic areas within. But can you see that there are solid areas too? So whenever you see such cystic lesion with solid areas, always get FNAC done, and FNAC should always be taken from the solid areas. Okay. Sometimes this is a small cystic, but this turned out to be a papillary CA. So papillary CAs can also give rise, can also show cystic changes within. Okay. Sometimes they might show a papillary projections within the cyst, and these are all important signs of papillary CA. Now let us come to lymph nodes. Now first I'll be showing you how normal lymph nodes look like. So in image A, here you are able to see this is a vessel. This is common carotid artery. Okay. This is common carotid artery. And here besides common carotid artery, this again an anechoic structure which you are able to see. This is IJV, internal jugular vein. and just anterior to this, are you able to see this structure? This is a lymph node in transverse section. The same lymph node in longitudinal section is this. This is longitudinal section and this is transverse section. So both of these are lymph nodes. Now what I want you all is to look at the center of lymph nodes. So can you see this structure at the center of lymph node? Okay, here corresponding. So this structure at the center of lymph node is nothing but hilum. So lymph node कैसा दिखेगा? एक lymph node रहेगा इस तरह से and center में there will be hilum. This is how normal lymph node looks like. And there will be vascularity within this. So you will see that there is a hilar artery which is going and then dividing and supplying the lymph node. This is how you see the normal lymph node. Now lymph node has got two important dimensions. One is this dimension which is called long axis, and one is this dimension which is called short axis diameter. Okay, SAD, short axis diameter. Now in head and neck, in the neck region, if short axis diameter is more than 8 mm, that means that the lymph node in head region is enlarged. Okay, more than one thing is you look at the enlargement. दूसरा important feature, the second important feature is that you look for presence of hilum, whether the hilum is there or not, or hilum is lost. Now suppose in if suppose the hilum is lost and suppose the lymph node becomes round. So number one is the lymph node becomes round or heterogeneous. Number two is there is loss of hilum. Loss of hilum. Number three, you put vascularity box. And suppose you see vascularity outside, but there is no vascularity within lymph node. So if suppose the vascularity is lost, in this case, this lymph node is termed as necrotic. Necrotic lymph node. Okay. Now, there are multiple causes of necrotic lymph nodes, including very important, which is tuberculosis. But this is how you look at the lymph nodes. Now, the point about this is, now look here. Can you see that this is hypoechoic lymph node? And are you able to see that the hilum is still there? But the lymph node is enlarged in size. It has become heterogeneously hypoechoic. And if you put the color box, you are able to see that there is increased vascularity within this nodes. Okay. So that again indicates that this is a reactive enlargement, non-necrotic. This is a reactive enlargement of the lymph node. Had it been the vascularity was not seen, this was necrotic. Okay. So when it comes to papillary CA, sometimes you might see solid nodes with calcification. Sometimes you might see cystic lymph nodes also with papillary projection. A very important feature is that you see calcifications within the lymph node. Okay. So now this is the classic lymph node in papillary CA. So can you see that this is a lymph node, very classic, and you are able to see multiple calcifications within the lymph node. So this is a classic METS in case of papillary CA of thyroid. Okay. Now, very important. In next slide, I'll be discussing the various important types of lymph node appearances on ultrasound. So let us come to this image. You have 9 different images, and this will clear everything about how the lymph nodes appear in papillary CA. So now you look here in image A. Let us start from A. So here you are able to see lymph node. If you see size wise, this is hardly 8 by 3 by 7 mm. But you see, is there hilum? Hilum is not there. So loss of hilum with heterogeneous appearance. This turned out to be metastatic node in case of papillary carcinoma of thyroid. एक और बात, कभी कभी papillary carcinoma of thyroid बहुत ही छोटे होते हैं, लेकिन उनके मेट्स जो lymph nodes होते हैं वो बड़े होते हैं. We call them as aberrant thyroid. Okay, so sometimes the patient might present with lymphadenopathy. That might be the presentation. They might give a clinical diagnosis of tuberculosis. If you see calcification, you might initially mistake it. This is cystic nodes or necrotic nodes of tuberculosis, but you should always look for thyroid. So lymph neck के lymph nodes है, thyroid देखना है, thyroid में lesion है, lymph node देखना है. बहुत ही important. That's the rule of ultrasound. Okay. Now let us come to another important image. So here you are able to see in image B, that these are enlarged lymph nodes, and along with enlarged lymph nodes you are able to see multiple cystic areas within the lymph node. So you can see cystic changes within the lymph node also in case of papillary CA. Now here let us come to image C. So here you are able to see a cystic lymph node, and very important, this is a cystic lymph node, but you are able to see certain solid areas. So I want you all to focus on solid area which is there within it and which is showing papillary projection. So this is papillary solid area within the cyst. And most importantly, can you notice that there are tiny microcalcifications within the cyst? So along with solid areas, there are tiny microcalcifications within the cyst. Now here again, are you able to see this very well defined lymph node with microcalcification? Here again, you are able to see lymph node in image E, and you are able to see microcalcifications within. See the similar looking node here with microcalcification. Now look here again, there is a small node but hilum is not there and it is heterogeneous. This is a large enlarged node which is heterogeneous with loss of hilum. Should also put vascularity. Of course the vascularity here was increased but not shown here. Now here in this case you are able to see that a hilum, the morphology of hilum is completely changed with heterogeneous appearance in half of the node. So that again is a very important feature of metastatic adenopathy. So this is how if I summarize all the lymph node findings, is number one is the heterogeneous appearance, number two is loss of hilum, number three is cystic changes, number four is you can have papillary solid projections within these cystic changes, number five you can have microcalcifications. All of this are very important signs of metastatic nodes in papillary carcinoma of thyroid. Hope you have enjoyed this session. I would love to tell you all that I really see your feedbacks, whatever you give. So I request you all to send me feedbacks, okay, in the comment section below, so that whatever you need, how the lecture was, you can of course comment about that in the comments below. Thank you.